Greetings to each of you attending the 2021 John Suydam Kuhlthau Bioethics Conference. We're delighted that you are here. Our theme this year is Look on My Suffering and Deliver Me, an interdisciplinary dialogue on medical aid in dying law in New Jersey. This focus is important as it considers suffering and dying in relationship to the physician's involvement in the death process, and this is a matter that is important to physicians, chaplains, pastors, and other caregivers involved. This year we want to recognize the passing of our benefactor and namesake of this conference, Dr. John Suydam Kuhlthau. Through his generosity, this conference exploring the subject of bioethics has been made possible. Ecclesiastes chapter 2, verse 26 states, "For to the one who pleases God, God gives wisdom and knowledge and joy." Dr. Kuhlthau's life pleased the Lord. Time will not allow me to list the accomplishments and memories of this great man who died on September 4th, 2020, but three exceptional memories would be: Dr. Kuhlthau always greeted you with his warm smile. Dr. Kuhlthau was married to Dr. Carol Kuhlthau for 62 years, and together they raised three wonderful daughters, Eleanor, Anne, and Leslie. Dr. Kuhlthau was a charitable man, providing scholarships for minority students at the Pemberton School, founding member of the board of the P.T. Green Prisoner Assistance Program at Princeton University, supporting New Brunswick Theological Seminary via this bioethics conference. We at New Brunswick are grateful to this great man, and as always, we greet you. Because you are, we are. God bless you.
Welcome to the 2021 John Suydam Kuhlthau Bioethics Conference. It is a special privilege to welcome you to this year's conference focusing on the medical aid in dying law of New Jersey. The John Suydam Kuhlthau Bioethics Conference is sponsored by the New Brunswick Theological Seminary in collaboration with the Rutgers Robert Wood Johnson Medical School, the Robert Wood Johnson University Hospital, Barnabas Health, and St. Peter's University Hospital. It is made possible through the John Suydam Endowment, which was established by a generous donation from the late Honorable Judge John Kuhlthau and his wife, Dr. Carol Kuhlthau, who continues her support. Today's conference theme, Look on My Suffering and Deliver Me, an interdisciplinary dialogue on the medical aid in dying law in New Jersey, affords us an opportunity to reflect on the nature and fragility of the human condition, but also the strength and resolve of our desire to be compassionately empathetic and responding to those who are terminally ill. To assist us in our deliberation on this issue, we have invited three highly capable scholar practitioners who have given serious consideration to this issue. They are Dr. Jessica Israel, Dr. Nancy Duff, and Dr. Lauris Kaldjian, whose bios are in the registration packet. We are truly grateful to have them there as presenters this morning. And we are deeply indebted to a wonderful steering committee of physicians, nursing, social work, and pastoral caregivers who have met together for over a year in planning today's event. I hope that you will reap the benefits of their hard work in exploring this issue. To receive contact hours for this activity, you must stay until the end of the program and complete the evaluation. The speakers disclose no conflicts of interest, receive no relevant financial support, and will not discuss off-label use of any product or device. We have not received sponsorship or commercial support for this program. Again, I welcome you to the 2021 John Suydam Kuhlthau Bioethics Conference. And without further delay, I yield to Dr. Jessica Israel.
Thank you. I'm going to go ahead and share my screen. All right, so I'm going to talk for 10 minutes about medical aid in dying in New Jersey. Happy to be here with you. I just want to point out at the beginning, unfortunately, I'm going to have to leave this conference a little early, but the host has been great in terms of answering questions. And if there are questions that come up for me after I sign off, I'm happy to answer them via email after the conference, but I'll try to stay on as long as I can. All right, so let's get into it. I always start with a definition because I think it's super important for us to level set and all be on the same page as we move forward, because this can be a confusing definition. So medical aid in dying is when a terminally ill, mentally capable person who has a prognosis of 6 months or less requests, obtains, and if their suffering becomes unbearable, self-ingests medication that brings about a peaceful death. It is a recognized medical practice in 9 American jurisdictions. I say jurisdiction because Washington, D.C. is not a state, requiring doctors to inform terminally ill patients about the full range of end-of-life care. So I'm going to talk about the law. I'll filter in a little bit of my experience along the way. I want to point out this is not physician-assisted suicide, and this is probably the most misunderstood part, and that's why I start with definitions. Assisted suicide is suicide undertaken with the aid of another person actually administering to that person the medication, and this is very different than that. I listed here the states. These slides are available for you, so there's a little bit of extra information in here that I won't have time to touch on, but at least you'll have the slides to look at. So who is eligible for medical aid in dying in New Jersey according to the law? You have to have, a person has to have a terminal stage of a fatal condition with a prognosis of 6 months or less. They have to be mentally capable of making this decision, able to self-ingest medication, able to voluntarily express their wishes both orally and in writing, and that they need witnesses to see this request and to provide some verification. I'll point out here, as I will as we move forward, that there's already, you can see a lot of stopgaps and a couple of things that make this difficult. One, you really need to be mentally capable. It's important. Family members can't decide this for someone else. It has to come from the individual. A patient has to be able to self-ingest medication, and this can be hard for patients who are in the terminal stage of disease, especially if it's a neurologic illness. You have to be able to speak, you have to be able to write, and you have to have people that will attest to what you've said. So there are some stopgaps here along the way, and maybe for certain patients with serious illness, some barriers. I'm going to quickly review what the law mostly goes into, which is the role of the attending physician and the consultant physician. I'll start with the attending physician. I'm not going to touch on everything, but it's in the slide. I really kind of summarized what the law requires, and that way you'll have it to refer to. But essentially, an attending physician is responsible to make the determination of terminal illness, to make the determination of capacity, to inform the patient of the diagnosis. And I'll say the last point on this slide is the most important thing, and that is really the crux of, I think, the law in New Jersey. It's the attending physician's responsibility to really open a dialogue about all of the aspects of end-of-life care. And this is really important, and I'll stress even from experience that there are many patients who don't know everything that's out there that's available for them, including meaningful palliative care consultation. So, and just some of the aspects of hospice care that maybe aren't well understood. So I'll talk about this a little bit later, but this I think is a really important part of the New Jersey law. Here also, in listing the attending physician responsibilities, and again, there are a few slides on this, I'll just comment that if the attending physician or the consulting physician feels that there's any need to refer to behavioral health, perhaps in someone who is significantly depressed that's making this request, or anything that you think may be kind of coming into play with judgment from a behavioral health perspective, you're required by law to refer to a behavioral health consultant as part of the process. Again, another place where we want to make sure that this request is coming correctly from a patient without anything clouding what they're saying. The law also strongly requires participation in palliative care consultation. Again, more about the attending physician responsibilities. Of note, at each time that the attending physician comes into contact with the patient, they are asking, I want you to know that you have the right to rescind this at any time. Again, reminders along the way. The consultant physician is another part of the law. It's not the physician that writes prescription. The consultant physician is not involved as much in the process. Basically, what they are saying is, yes, the patient has a serious medical illness. Yes, they have a terminal diagnosis. My timer keeps going on. And yes, they're capable of making this decision. And again, that's another place for the consultant physician to say, you know what, behavioral health may help us here. So even if the primary physician doesn't think behavioral health is necessary, a consultation, and the consultant physician does, that's the avenue that gets taken. If all the requirements are met, and there's some time requirements, and you'll read about these in the slide, and 15 days has elapsed from the time of the initial request and 48 hours from the initial written request, and then these prescriptions can be written. Just really important to point out, this is voluntary. The physician in New Jersey does not have to write a prescription or be involved in this process at all. Really, the most important part is the open and honest discussion about what's available for patients at the end of life, and then if a patient really wants medical aid in dying, a referral can be made to someone who feels comfortable doing this, but no one is required to do this by the law. Same thing for healthcare facilities. Healthcare facilities are required to be able to talk about it, but not to have to provide it. I'll just point out a couple quick things in the couple of minutes I have left about what the law really does. I love this slide because it talks about how it really opens a dialogue, and how if you mention medical aid in dying, it doesn't mean that that's what that person is going to do, but it opens a dialogue that helps to inform patients of what might really help them along the way, even outside of medical aid in dying. Medical aid in dying, from the experience that we know about in Oregon, which is our longest experience, shows us that these discussions lead to more hospice utilization and earlier hospice utilization. And that is a really good thing for patients who are experiencing suffering and need that extra support. And most patients die at home. I think this is one of the most interesting things that we learned from Oregon, and we've also seen, I even personally have seen in my own practice, that 2/3 of people who receive a prescription for medical aid in dying will never use it. And not necessarily because they die in the process before they're able to ingest it, but because they're opting not to. I think it's an option, it's control, it's knowing that there's something there, perhaps, that is important, and not necessarily ingesting the medication. So you can see here from these Oregon statistics that I put in here, not a lot of people use medical aid in dying. It's not because it's out there, it doesn't mean that everyone utilizes it. And in New Jersey, in the first year, there were 12 cases, and certainly there were way more patients with serious life-ending illness along the way. I thought this was interesting. I always thought that the primary reason that someone would request this was something that I could treat medically. I always thought it would be uncontrollable pain, and I could offer a good option, or even or even depression, something like that, where I can offer an option that may change that person's outlook. But really, it's overwhelmingly engaging in activities and autonomy that are the main reasons. I'm going to just whip here just to talk for a second about challenges. So these medications are not covered by any insurance, right? So, and neither really are the consultations. So that's another important barrier. Doctors don't really know which medications to use, although now there are some standards. They're hard to find if you try to look for them. And since they're not covered, again, this limits medical aid in dying to a population that can obtain these medications from the pharmacies that will provide them in New Jersey, and also pay out of pocket for them. And I think that that's an important concern when we talk about ethics, because it's not equal access for all, and something that we should think about. All right, I went super quick to try to be within 10 minutes, but I think if you taking away some high points, thinking about the definition, and I'm sure that you guys will talk a little bit about that later today, and also the ability and the understanding to have a full range conversation with patients when they request medical aid in dying, because very often they're talking about something that needs attention, and in many cases, you can supplement that along the way. So that is the end of my time. So I am going to turn this over to my colleague, Dr. Nancy Duff.
So I'm going to talk today about in defense of medical aid in dying. The law is legal now in New Jersey, but we know that the debate will continue. There's still a lot of people who don't think that it should be legal. And so I'm going to spend some time talking about the pros and con arguments from three different groups, but there are a few things I want to say, just some preliminary comments. One that's just been covered, the reason people choose medical aid in dying really has to do with the disease reaches a point where life is no longer a gift, but a burden. So these were mentioned: loss of control and loss of independence. You can't participate any longer in enjoyable and meaningful daily activities, loss of dignity, fear of or experience with the dehumanizing aspects of some residential care places, and fear of acute pain is there, but it is interesting that that is typically not mentioned first. Language is important. Physician-assisted suicide is what almost everybody said when this debate first started, often abbreviated PAS. It is still used by some people who are opposed to it, not because they think this is suicide and that we shouldn't be helping people commit suicide. Those who are in favor of the law begin to say this isn't suicide the way we typically think of it. People who turn to assistance in dying don't want to die. They want to live. But so that's a different understanding than we usually have of suicide, but the disease is not going to make that possible. So they want to choose when and where and how they die. And so the language of physician-assisted death became popular, and death with dignity is common. That's the way a lot of people refer to these laws, death with dignity laws. People who are opposed will argue that there's nothing dignified about helping somebody die. Medical aid in dying has become more common, and that's medical aid in dying. That's the name of the New Jersey law. Now, as has been pointed out, if someone refers to this as euthanasia, if that's what they mean by assisted suicide, that's simply incorrect. It is illegal in every state in the United States for there to be direct action, giving a lethal injection, for instance. So that language is actually inaccurate. I want to say just a few things about the slippery slope, because it often comes into debate on this issue. Is it a legitimate argument? We all know what that means. The reasoning is if we start with medical aid in dying, we're going to go down this hill. We're going to come to voluntary euthanasia, where doctors can give a lethal injection. But then we're going to go all the way down to the bottom of that slope to involuntary euthanasia, where people whose lives are considered worthless, their lives are going to be taken away against their will. The question is the slippery slope legitimate, or is it a philosophical fallacy? A lot of people will argue that it is a fallacy because that descent isn't inevitable. Because I start here doesn't mean I will automatically end up down here at the bottom of that slope. I actually agree with that. And yet I think that intellectual courage requires us to invoke the slippery slope. We need to consider, if I start here, where might I end up that I don't want to? And once we invoke that image, we need to consider where our reasoning could lead and then ensure that we don't go further down that slope. So I'm going to give pro and con arguments from three groups: people with disabilities, physicians and other members of the medical team, and Christian groups. My aim in doing this is to explain why I am in favor of this law. For people with disabilities or their advocates, such as a group called Not Dead Yet, that's the name they chose. It comes from a Monty Python skit. Their primary concern, which is admirable, is they want to protect people with disabilities, and for good reason. There's a horrible history in our medical history of abuse and neglect of people with disabilities. If you have ever heard of Willowbrook School in Staten Island, from 1947 to 1987, people with developmental disabilities were abused and neglected in horrendous ways. And it's still true that there can be a lack of societal support of people with developmental disabilities or physical disabilities, and so they can be made to feel worthless. So there is a fear that this law is going to be used against them. And the primary argument that's put forth by organizations like Not Dead Yet is the slippery slope. They insist that if you start here with medical aid in dying, we are going to end up with involuntary euthanasia and taking the lives of people with disabilities against their will. On the other side, in favor of, I certainly agree, we should fight against discrimination, be aware of it, make sure that the medical world is giving excellent access to excellent care to people with disabilities. But that doesn't mean that those groups like Not Dead Yet can dictate what others do, can say that the others of us should suffer rather than choose death if choosing assistance in death is what we want. And I can say that in part because I don't think that the slippery slope is inevitable. It's also true that some people with disabilities want access to medical aid in dying, and they think it's patronizing for people to tell them what they ought to be able to do. And as Jessica pointed out, some patients, such as people with ALS, they want access to it and they can't, because by the time they're 6 months away from a prognosis away from dying, they can't swallow, they can't administer the lethal drugs themselves. Often in that community, and ALS and others, they turn to something called VSED, voluntary stopping eating and drinking. Pro and con arguments from physicians and healthcare workers, arguments against medical aid in dying. Physicians will also often say, I am trained to cure, not to kill. And there's a fear that patients won't trust them if they know that their physician would eventually help them die. I'd like to say also, though, the opposite, some patients won't trust them if they know their physician won't help them die. Once cure is impossible, they've fought the good fight, they're tired of fighting the disease, and they're ready for a prescription to help them die. And they want to be able to trust their physician to be there to help to support them in that. There are religious and philosophical beliefs of individual physicians that make them stand against it. That was addressed, that is respected in the law. They don't have to participate. There does, though, by law need to be a referral made. Now, I know that some physicians in Canada who are against this practice also are against any involvement in making such a recommendation. They say, why should I recommend someone to go to a doctor to do something that I think is wrong? That's something I'd like to hear from physicians who are against this, if they would also not want to be involved in giving a recommendation. And then finally, the medical world, physicians and others argue this isn't necessary. There are alternatives. Pain management is often put forth. We can manage your pain at the end of your life, is a promise made. I think that's a promise that can't always be kept. Not all pain can be controlled. In situations of tremendous pain at the end of life, even with pain management, there can be breakthrough pain that the medication just couldn't keep at bay. Well, there's terminal sedation to try to prevent that kind of breakthrough pain, but not everybody wants that. Brittany Maynard, who took in a very public way advantage of this law in 2014, said she didn't want to spend the last days or weeks of her life terminally sedated, all of that money and energy with her just being unconscious. And as has already been pointed out, there are other reasons for medical aid in dying besides pain management. Other people will say, well, hospice is an alternative. We can keep you comfortable till your last day. In 2014 in Oregon, 93%, Jessica said 90% of patients were already in hospice when the prescription was written or when it was utilized. So those aren't, they're good things, pain management and hospice, but they don't necessarily offer options for medical aid in dying for those who want it. Finally, pro and con arguments of different Christian groups. The argument against medical aid in dying is almost always based on divine sovereignty. Our lives belong to God alone. God gives life. Only God can take it away. We shouldn't play God. That's a very frequent argument put forth and a thoughtful one by some Christians. I would like to suggest, though, that we're already playing God in any number of ways in medical situations. First, by keeping people alive when their time to die has arrived, and there's really nothing more we can do except extend their dying. And I think that's as much playing God when that's the way a patient is treated. I also think we could use the phrase playing God when we claim to know what's best for someone else. Well, you say that you want assistance in dying, but really that's not what you ought to do. I personally would just like the phrase to be put to rest. I think playing God, it's vague. I don't think that it helps the theological argument if you're arguing as a religious person. Other Christians who are against medical aid in dying will say autonomy, which looms large in this debate. I should be able to decide what I want to happen when I have a terminal illness. That autonomy is not a Christian value. Christian faith is relational. I actually agree with that. And I think many of us would agree that autonomy looms too large now in the medical world, with patients being able to demand treatment that the medical team doesn't think is appropriate. In this case, people demanding access to medical aid in dying. I don't think, if speaking in a Christian context, that autonomy is a Christian value. I hope people will be able to talk to family, talk to other people in the Christian faith about what they want to do. But the opposite of autonomy can't be the tyranny of opinion of others dictating what a dying person should do. And finally, some Christians will say suffering has a purpose. They'll even use the word suffering is sanctified, holy, and so that a Christian should be willing to meet the suffering in the context of their faith in Christ all the way till the end of their life. And I, as a Christian, don't agree with that. I respect that that's what some people think. But again, others shouldn't impose their beliefs that suffering has a purpose on people who don't agree with that. As a Christian, I believe there is such a thing as senseless suffering that has no purpose. And I think I want to support people who want to turn to assistance in dying, because, as I said, life has now become a burden more than a gift, and there's no purpose for them to have to go through that suffering. It's not an argument, but just a point of fact. One survey showed that 38% of white evangelical Protestants support medical aid in dying, which was rather surprising. Conservative on other issues, they nevertheless think that a terminally ill patient could rightfully, morally turn to assistance in dying. To address very briefly some problems and responses to them, there is a real concern that patients can be coerced by family members. Well, it's legal now. Why don't you just go ahead and take your life? So the right to die becomes the responsibility to die. I think we have to be very careful in the kind of interviews Jessica was saying, the interaction with the patient a person who says that they want access to assistance in dying, to make sure they're not being coerced. But I also think on the other side of that, patients can be and already are sometimes coerced into accepting new treatments that actually the person may not want, and into assuming the role of one who can get better. Often patients aren't allowed to assume the role of one who's dying and be treated as someone who's dying. Both those kinds of coercions we need to be aware of them and make sure that that's not influencing a patient. Some patients may choose medical aid in dying because they want to spare their family financial and emotional burdens of care. Again, a very big concern. The family may not be ready for them to take this route. They don't mind the burden. And we need to make sure that the patient, the individual, isn't choosing this out of just this need to protect the family. But I do believe there comes a point where the financial and emotional burdens are just overwhelming, and it's quite legitimate that the person is saying, I don't want this anymore. I don't want this kind of money and energy and time spent on my dying. Finally, physicians, one potential problem, who willingly follow a legal request for medical aid in dying may nevertheless experience moral distress. In your packet, there is a reference to an essay Jessica Zitter, a physician, wrote for the New York Times. It's available online. She says that happened to her. She agrees with this law, but when she received the first request, she didn't know exactly how to follow through on it, and she found herself just a lot of anxiety about it. That's also true in other situations, that physicians and other medical people can experience moral distress. Jessica Zitter argues hospitals need to have really clear protocols in place about this is what you do when you get such a request. And she suggests that some physicians need special training, that they know all about this, and that they may be someone that another physician would turn to for advice, and even to talk about, I agree with this, but I'm finding it difficult emotionally to follow through with it. And then finally, I will end with reflecting briefly on what can religious institutions do and to help with this law. The first thing is get people in your congregation to talk about death. It's a huge problem that people don't want to. And so how can we encourage people to talk about their own deaths? I would like to see people be able to discuss what do they fear the most about death, and do they feel safe talking about their fears in the context of a religious institution, a gathering in their congregation. Do they have a living will, an advance directive? And once you get people talking about death, then also be informed and help members of your congregation be informed to talk about medical aid in dying. Make sure they understand New Jersey's law and provide an environment for discussion, and including disagreement, a safe environment. I think it could make a huge difference if religious institutions could help prepare people, talked about their death, talked about this law before they're facing a terminal illness and wondering whether or not they want to turn to medical aid in dying. So those are my remarks, and I will now turn this over to Lauris Kaldjian for his presentation.
Thank you very much. I hope everyone can see and hear me properly right now as I have my part of this Zoom reality to share with you all today. First, a very warm greeting to everyone, wherever you happen to be. I'm here on the other side of the Mississippi River in the heartland in Iowa City, Iowa. And it's a beautiful morning here. I hope it is there in New Jersey and on the East Coast. I also spent 11 years in Connecticut up the expressway from you all, so I appreciate the benefits of places eastward from here. Thanks also to the steering committee and to Steve Mann for managing the wonders of Zoom for us this morning. Let me also say that I'm going to have to move quickly through a larger number of slides than I would otherwise prefer to, but in the interest of time, I'm going to, in musical terms, be a bit of an allegro con moto, as opposed to a more relaxed andante. And I also would say that if anyone would like a copy of my slides or references, please email me. I'd be delighted to share those with you. So, this is an issue that is ancient. And you can see from an English translation of the Hippocratic Oath, the question of using deadly drugs has been with physicians for the time since they've been physicians. So there's nothing really new under the sun here. And the question now is, why have things changed? And it's not because of technology, but it's actually because of attitudes towards it. As has already been discussed, assisted suicide, which you can see I call assisted suicide. So with all due respect to Dr. Israel, I am one who believes that is the most accurate descriptive language to use, and I'll be explaining that a bit more as I proceed. But you can see how physician-assisted suicide has been legalized in different parts, and then by contrast, active or so-called euthanasia in some European countries and in Canada in 2016. I want to say, though, that something is not ethical just because it is legal. History clearly makes that clear, sadly enough. However, the act of legalization can have a legitimizing effect that may change attitudes over time. And if a practice remains ethically controversial, the ethical legitimacy of its legality remains debatable. So I'm first actually going to give 9 reasons why I believe physician-assisted suicide is mistaken and harmful. I'm not going to discuss them. I just want to let you know these are my sort of best reasons that I could offer right now today. And then I'm going to go on actually to 9 areas that I believe need clarification so that we can have a better understanding of what's actually going on in this thing that we refer to, at least some of us refer to as physician-assisted suicide. So I believe that this practice lessens respect for human life and thereby weakens the moral fabric of society and medicine. It fails to appreciate that the purpose of medicine is to care for the sick, not eliminate all suffering. It medicalizes suicide and turns an individual decision into a socially approved prescription. It's not driven by the need to alleviate pain, which palliative care effectively provides, but by an existential desire for control, independence, and not being a burden, based on contested beliefs about human dignity, suffering, and a life worth living. It looks to physicians for something they don't have: expertise in meaning, purpose, and knowing when someone's life is no longer worth living. It requires shared decision-making and depends on a physician's beliefs about deeply philosophical and religious issues, so it is not merely a matter of patient autonomy. It fails to appreciate that patients are susceptible to coercion. The option of PAS may become an expectation, at least in some cases. It's likely to facilitate an attitudinal shift among at least some health professionals. A patient's option for assisted suicide may become a professional's recommendation for it, at least in some cases. And this is not about the negative right to be left alone. It presumes a positive or so-called entitlement right to be assisted in suicide, something that the US Supreme Court actually denied in 2 landmark cases in 1997. So first, the point of clarification about language. Dr. Duff already addressed some of this. This is a study from the state of Washington from some hospices. And you can see the 6 different ways that those hospices, differently among them, refer to this. And the authors nicely point out that how the practice is described is not value-free, but presupposes value assumptions that inescapably influence moral assessments and policy positions. So this is an active question, even at the level of language. And when you look at the statutory law in New Jersey, you can see that it actually describes this practice as to obtain medication that the patient may choose to self-administer in order to bring about the patient's humane and dignified death. If you look at Webster's definition of suicide, the act or an instance of taking one's own life voluntarily and intentionally, I think those are basically the same thing. And so it seems strange then, of course, that then when you read other sections of the law, it says that none of this will constitute suicide or assisted suicide. And then the modification of the law regarding aiding suicide, the law is stated, and then it simply says that this shall not constitute suicide or assisted suicide. In my mind, there is a neglect of a plain use of language, and instead carves out the space that says, well, legally speaking, we're not going to consider it this way. I don't think that actually does a service to the public's understanding when we basically change the use of language in order to advance a policy. The AMA happens to agree with this. The AMA revisited this question just at the same year that New Jersey legalized the law, and they confirmed that assisted suicide is fundamentally incompatible with the physician's role as healer. And notice also that they recommended plain descriptive language. And in their view, the term physician-assisted suicide describes the practice with the greatest precision. How about the cause of death? If you go to the CDC's website, you as a physician can be educated on how to fill out a death certificate. Notice the first line, immediate cause of death. And interestingly, in the New Jersey context, the form that a physician has to fill out, the attending physician follow-up form, actually does specify whether or not medical aid in dying was used. But, and I learned this by speaking to a kind staff member at the New Jersey Office of the Chief State Medical Examiner a few days ago, you are not allowed as a physician to say anything about medical aid in dying on the death certificate. That to me is problematic because that's not even a misuse of language. It's now a misuse of scientific description if we're not allowed to actually document what actually has happened. And I think you can appreciate why this happens if you read some of the early language in the statutory description that you can find online. That in this opening paragraph, whoever drafted the law, they are merging together into one continuum, the right to forego treatment with the right to be assisted in suicide. But these are not the same things, logically speaking. And in one case, the cause of death is a disease. In the other case, the cause of death, the immediate cause is a drug or multiple drugs. And in 1997, the US Supreme Court explicitly addressed these questions and said there is no constitutional right to be assisted in suicide. How about dignity? Obviously a wonderful word, a big word, and a word that means different things to different people. Those who drafted the statutory law refer to a humane and dignified death, but they don't offer any definitions for humane or dignified. I guess they assume that we're all on the same page. I don't think that's a fair assumption, actually. And you can find a lovely publication that was put out by the President's Council in 2008 entitled Human Dignity and Bioethics. One of the essays there is by Leon Cass. And just to give you one example, he points out that there are at least two different fundamental approaches to dignity. One is based on life, the other on so-called quality of life. So whenever we talk to each other about dignity, we owe it to each other to explain what we mean and see if we agree or disagree on that. How about motivation? As has already been discussed, control and autonomy are key in this discussion. And you can see here, I've drawn from Daniel Callahan and Gil Meilander, some wonderful quotations where they address this from a vantage point I think is profoundly insightful. And Callahan writes, the movement for legalized euthanasia, and here you can also say end assisted suicide, rests on the assumption that we have a right to and necessity of full control over our fate. The argument for euthanasia or assisted suicide seems to be agreeing about the centrality and validity of control as a goal. If medicine cannot now give us the health and continued life we want, it can and should at least give us a total control over the timing and circumstances of our death. And Meilander says, trying to orchestrate the circumstances of death has the look of one last attempt to be what we are not, the author of the story of our life, and euthanasia or assisted suicide misses the irony that we are attempting to master the very event that announces our lack of mastery. And if you look at the data, we've already seen this, but you can see this is what the report looks like when you go online to see the data from Oregon. But if you look over here, the percent frequencies, the great preponderance of rationale has to do with enjoying life activities, autonomy, dignity, et cetera. Pain control or even concern about it is relatively infrequent in that regard. So it's really about autonomy. How about medical expertise in terms of why is this physician-assisted suicide? If one thinks about a biopsychosocial spiritual dimensionality of health, you might sketch it out like this. So you think about these different domains, and then you say, well, who is the expert in these domains? And so the question I would have is, what would make a physician an expert capable of prescribing physician-assisted suicide? Shouldn't such a responsibility actually be the purview of someone else? If you think about the existential questions of meaning and purpose and a life worth living, wouldn't it be better to have a pastor, priest, rabbi, or imam assisted suicide? Because surely they get training in these kind of questions. I went through medical school. I teach at a medical school. We don't teach students this kind of expertise. Unless, of course, physicians are being treated merely as technicians to provide drugs that can be used and prescribed in that sense. So it's really a question of this medicalization of something that really at heart is not a medical problem, as understood. There's also the concern about physician influence. So here we can think about so-called shared decision-making. And so in shared decision-making, it's a two-way street. And that's any of you who have had really good, doctor-patient relationship experiences. Thankfully, you know what this looks like. And doctors should make recommendations. And there's no way for a doctor to separate who they are and what they believe from what they're discussing with their patients. So if you think about foundational beliefs and values relevant to assisted suicide, you can quickly glance at the list here, which covers a huge amount of terrain, right? And so I believe there's no way to rationally presume that a doctor can separate him or herself from their beliefs about these things, especially the moral significance of suicide, of someone taking their own life. Is that rational or not? And can this be a healing act or not? There is no textbook of internal medicine that's going to answer that question. That's a philosophical and religious question at heart. And indeed, it's interesting if you look at what percent of patients in Oregon who receive prescriptions for assisted suicide actually avail them or actually are referred for psychiatric evaluation, less than 5% over the last 20 plus years. That to me is very surprising. Given the frequency of depression toward the end of life, this to me doesn't seem right at all. And it suggests to me that the doctors who are working with patients who request this are more in sympathy, shall we say, and see more eye to eye with suicide as being a legitimate option. I won't go into this, but if any of you are interested, this is a very interesting paper written by a psychiatrist and his colleagues about the role of countertransference and ethics in end-of-life care. Remember, physicians are human beings. like you, right? They are not somehow automatons or mere technicians. They have their own minds and hearts and souls, and things can be very complex at times. There's also this idea of relational autonomy. We often hear autonomy, but relational autonomy is a very important thing to think about. And I try to teach this to students because often autonomy is reduced to choice in our society and in our medical schools and hospitals, frankly. If the patient chooses it, it has to be the right thing, sort of in a self-justifying sort of way. But in good shared decision-making, that's actually not what's going on, because physicians are constantly working with a sense of what they think is good for a patient. I'm not saying they're not respecting a patient's freedom to say yes or no, but there's a lot more going on in the complexity of these relationships. And I appreciate some very thoughtful philosophers and ethicists who say, actually, there comes a time when we actually have an obligation to try to shift a person's perspective, to give them better reasons on their own terms for seeing something differently. I think all of us who've had really good discussions with people we know and trust and who we want to listen to, sometimes we've had our own positions change because we realized we needed the help of someone else to help us see something better. How about conscience and integrity? So these are my definitions. This is just, well, not mine. This is from the dictionary. And then this is a definition I offer for integrity. I tend to see these two terms and ideas as being very interchangeable. And this is a whole nother discussion unto itself, but it's profoundly important to take seriously the moral integrity and agency of every clinician in their work. It's vital for professionals, it's vital for the profession, and it's vital for patients. We would never want to simply use physicians for social purposes as if physicians were not human beings with their own moral agency. And as has already been said, thankfully, the statutory law in New Jersey recognizes the need for this to be voluntary, both for individual professionals as well as for institutions. Notice that objecting physicians need not arrange a referral to a non-objecting physician. A patient can transfer his or her own care. But by contrast, as Dr. Duff intimated, in Ontario, actually, it's a whole different story. And despite 2 legal cases, in Canada, a physician's license is at risk if a physician is unwilling to make what they define as an effective referral to a non-objecting physician, which to me is profoundly undermining of physician integrity and, quite frankly, a violation of human rights. But that's another discussion unto itself. I was given a copy of St. Peter's Healthcare Systems policy regarding these things, and it definitely states the need to respect the integrity of healthcare providers. It also points out that there will be no participation in the activities under the Act, and they will not assist with or offer referrals. So that's a very nice expression of an institution taking this very seriously based on its own terms. How about suffering? The very word patient comes from a Latin etymology that means to suffer. So in one sense, every patient is a sufferer. Much can be said about suffering, and you can just glance at some of the things here. I would suggest that so many people have that it's part of the human condition. And as one person put it, it's a mystery to be faced, not a problem to be solved, and certainly not a problem to be solved by medicine or healthcare. And in healthcare, it creates all sorts of difficult things, including silence and distance. We need to keep company with those who suffer. And the sources of strength in the midst of suffering have to do with meaning and purpose. Those of you who know Viktor Frankl's work, you know what I'm talking about here. The need for hope, the need to be respected, to have that inherent dignity honored, and then to be loved. And Stanley Hauerwas has a book that's called A Suffering Presence. I like that phrase. And we need to commit ourselves to being a suffering presence for those who are suffering. How about compassion and companionship? The statutory law refers to compassionate medical aid in dying, but it doesn't explain what that is. It presumes that we all know what that is and that this is an instance of it. This is a very interesting reference that I've come across in the last few years by a colleague I met at a conference. And it's a wonderful thing to teach to medical students about teaching compassion as a practical 4-step process. And you can see right there. The last one, acting to attempt to alleviate the suffering in some way. I would just add here, without eliminating the sufferer. That may sound blunt to some of you, but I think I have to be honest and say that that's what's happening, right? When someone dies, they are no longer present. right? When someone is still alive but suffering, you can still keep company with them in this world. So this is how profound this is in the question of relieving all suffering or attempting to alleviate what suffering we can alleviate. Compassion needs reason too. So if we just act out of compassion, we can make some big mistakes. History demonstrates that very nicely. Ed Pellegrino wrote this nice piece some years back on these kinds of topics. And you can see here that compassion is a virtue, not a principle. It can become maleficent unless it's constrained by principle, hence the need for beneficence and non-maleficence. And we have to remember, of course, that autonomy is not an absolute principle. Right? We need to recognize suffering, and we need a deep sense of listening. Those who know Arthur Frank's work can appreciate this, and he writes very beautifully about what it's like to really listen well to people and how listening to people's stories is fundamentally a response to their suffering. So there's a great need for us to really be attentive to our patients. And one example of this comes, for those of you who know this remarkable novella by Tolstoy, The Death of Ivan Ilyich. It speaks profoundly about suffering. And it also gives an example of the selfless peasant Gerasim, who is the real one who actually serves as a suffering presence for Ivan Ilyich as he's dying. So in summary here, I very rapidly went through 9 reasons I believe physician-assisted suicide is mistaken and harmful. And then I went through 9 issues in need of clarification. So language, is it used to reflect reality or influence perception? Cause of death, is it a scientific description or a societal construction? Dignity, what is it and where does it come from? Motivation, is desire for autonomy and control the central story? Medical expertise, does assisted suicide medicalize what's really a social, spiritual problem and not a biomedical one? Physician influence, are patients actually acting autonomously? Physician integrity, does society respect freedom of conscience? Suffering, can medicine deliver us from our human condition? And compassion, how can we all be a suffering presence to keep company with those who are suffering? So thank you very much. I apologize for the rapidity of going through so many slides, but really if I can be of any help to anyone, you'd like a copy of the slides or references, please do email me at that email address. And with that, I will stop sharing my screen and hand things back to our coordinators here.
So this is Ted Taylor, and I want to thank Dr. Duff and Dr. Kaldjian, Dr. Israel, who did have to leave a little early, and there were some questions already starting to thread through the Q&A section that were directed right to Jessie. She did answer at least one of them, which was a question about brain function, assessing that for people who request an aid in dying, and another question about the cost of medication. We might be able to, between Dr. Kaldjian and Dr. Duff, maybe touch on those, although it's not the area of your expertise. So I invite, if more of those medical type questions come in, we will get those to Dr. Israel. She can reply to the individual. I'm sorry she was not able to address those particularly. So what we're going to be doing for the next 50 minutes or so is having a chance to have a dialogue with Lauris and Nancy, and to use the questions that are already coming in. We've got over 176 people on our conference, which is great. So it will not get to every question, I know. But let me go ahead and get started with a few that came up. And some of them are really kind of interesting and pointed. So one question is about culture and culturally diverse groups. And how have they been responding to this New Jersey law? And do healthcare disparities play a role in how people accept medical aid in dying? And there's a reference point to also, I think, Nancy, you had talked about how a key component of white evangelical Christians have accepted this. So I'll just throw it to either one of you to get started.
I don't really know the answer to that, except that one study that I read a while ago is that in Oregon, the vast majority of people who've taken advantage of the law are Caucasian. But what that means and how it would break out in New Jersey, I honestly don't know.
Yeah, I would just, obviously, I don't know the details in New Jersey. And I think when I was on the website, I saw that there's only 1 year of data, and it's that the numbers are very small. So I'm not sure that one could generalize. at all this point. But there's also a history of research, empirical research in end-of-life care and how much life-prolonging treatment patients and their families request of doctors. And there are definitely racial differences in that regard. And so there's a whole discussion to be had about trust and whether or not, what's driving the recommendations or the offerings of questions about whether to continue life-supporting treatment or not. And so that's something that we have to take very seriously when we are wondering about the unintended consequences of policies that might otherwise be supported.
Yeah, there's actually in our Q&A line already, several folks are asking about these the documented disparities for people, Black or brown-skinned people, and so talking about these guardrails to prevent inappropriate imbalances in racial cultural boundaries. And I think that even connects to an earlier question that was addressed directly to Dr. Israel that she can't necessarily answer, but she mentioned the imbalance of access because of the cost of the medication. And I didn't know if either of you had a response to that in particular.
Yeah, Nancy, would you like to go ahead?
Not really. I mean, it's a conflict. It's a problem in the law that this is legal, but which medications are going to be used, that should be very clear choices among physicians, and access to that medication. That yes, you have access to medical aid in dying, but no, you can't afford it. Seems to be problematic. But I know on the other hand, some people don't want there to be public support for helping somebody die. So I do think that it's difficult, but it also is reflective of the whole medical system we have, where it isn't just assistance in dying, but it's assistance in getting treatment one needs to live. That there are too many people in this country, people of color, poor people of all ages, races, they don't have access. And we've seen that with this pandemic writ large.
Yeah.
And if I could join in on that, Ted, to me, though, this is a really nice example of how we shouldn't rush too quickly into asking certain questions, because there are assumptions behind that. For those who disagree on moral grounds, ethical grounds with assisted suicide, it's not actually a form of healthcare. It's actually the opposite of healthcare. And so they would think this is not a question of justice. In fact, the injustice, they believe, is anyone providing it anyhow because it disrespects the value of life, right? And so what's interesting to me is an interesting sociological sort of research project is for someone to study all of the things that are done by physicians that are legal, but are not covered by insurance policies. And ask yourself, why is that so? So to what extent is our insurance mechanisms a marker of some kind of sets of boundaries about what the limits of healthcare should be in that sense? So that's an open question, and that may shift over time. I think there have been other examples of certain health-related practices that initially might not have been covered and later were. So who knows how that will go? But just because it's not offered, in my mind, that's not a problem. I think that's a good ethical sensibility. But that's, again, it's rearranging the problems before us here.
I just like to add that if assistance in dying isn't, that's not medical care, but it's also a problem in the history of medicine. There's a very bad record of pain management. Now, it's much better than it once was, but this relational idea where physicians actually reflect what I feel, when I had my hip replacement, I was hip replacement number 2 for the day. I wasn't an individual person. That surgeon knew. Now, I have other doctors who do know me, and I appreciate that. But I think studies show that people of color feel that they're given much less attention to pain management. And I just think if you're not going to agree that somebody has access to medical aid in dying, the medical world has to be a whole lot better at relating to patients who are in pain and who just are weary with a life where they can no longer do anything. It's not just, oh, I'm autonomous, I should be able to make a decision. It's I'm tired now of not being able to walk my dog or cook my breakfast and have other people have to take care of every basic function so that I'm just made to feel like a sick body. You have to really step up and not let, what are you going to do where patients aren't going to feel that way if you think that helping someone die is not helping take care of them medically?
Yeah. I'm noticing that the discussion when we're focusing right now on the cultural distinctions of access and to any type of care is important. One of our chaplain attendees talked even more broadly about saying, this pandemic has taught us that everything is political and economic, and the divisions in our culture right now. So was asking you all to address political and economic alliances that kind of frame the argument on either side of this issue. So how do politics and economics, money and power play into this?
Yeah, I guess part of me would like to narrow that question down. I mean, that's, in one sense, I guess that's like a blank check. One can answer that in a lot of different ways. And I'm not sure about the alliance. There's certainly alliances. I think that I would call the general sort of label of respect for life. Right? That's what I would call it. And I realize that's a loaded phrase because some people, I'm sure Nancy would say, of course, that she respects life, but she's respecting a choice about how long to live and then who's going to be the cause and what's going to be the cause of the end of that life. But from my vantage point, the idea of a natural death is a really real concept. And yes, as Nancy was saying, there can be concerns about, language like playing God. Yes, we have responsibility, but in my work for 25 years as a physician, I know the difference between an infection killing someone, a heart attack killing someone, as opposed to a physician killing someone or a medication killing someone. Those are very different realities that can be described scientifically. There's no doubt in my mind. The question is how long and how far do we go to keep people alive? Yeah, we're responsible for that. So we join, we have to be stewards of those decision-making processes. But I think in terms of the politics here too, I think one of the issues that and this has very much come up in the pandemic too, given all the concerns about rationing and triage, and do we have enough ventilators and all those sorts of things, issues of resource and cost are actually very much on the minds of many people. And I'm not talking about the cost of the medications to end someone's life. I think there are concerns in some people's minds, independent of the question of assisted suicide, when doctors say in an ICU are recommending to a family, we actually don't believe that this treatment is actually helping your loved one anymore. And we would encourage you now to think about pulling back and shifting the goals of care to comfort, et cetera. There are some patients who actually are suspicious of doctors and of hospitals and of nurses because they're thinking, well, are you doing this to save your time, your resources, your money? Or is it really about us? So if trust is not there to begin with, then I think all bets are off. And then you get into cross-cultural issues as well related to this, and different, subgroups of people in this country who have histories of distrust. I think there's a real recipe for a lot of misunderstanding, and we might actually be aggravating and inflaming an already questionable situation.
I want to say that I completely agree that there's something it's just not truthful if somebody dies because they ingested the lethal drugs, and that's not reflected on the death certificate. I don't know how death certificates can work, but I think noting that they had a terminal illness, what it was, but the final cause of death was the ingestion of drugs. That's just honesty and for record keeping for lots of reasons. I agree that it should say that it's dishonest otherwise. Oh, but the political alliance that I'm aware of, being on the ethics committee at the hospital in Princeton, is any time that doctors, far before you get to assistance in dying, they just want to have better avenues, talk to patients, have a consultation with a patient about death. Can there be a charge for that? Anything that they say, let's try to encourage people, the medical world encourage people to have living wills. There is a group of Christians, they're not a cohesive group, but there are Christians, their immediate response is, now we're on the way to death panels. That too is dishonest, and it keeps doctors, whether they agree with medical aid in dying or not, from being able to do something I think they all need to do better, which is talk to a terminally ill patient or someone recently diagnosed. But I think it's a small group of people who then say, oh, we're on the way to death panels, but they have had political influence.
Just one comment that already came through, and it is something that I kind of noticed too while we're talking about cultural differences and cultural distinctions, that so far all of us who've been speakers and panelists and hosts are privileged white people. So, there's that part of it that's in our discussion that we're kind of sitting here in that space too, just to be aware of who we are in our speaking right now. I'm really hopeful we break out into rooms in another hour, that will kind of be dissolved a bit, because we'll have a lot of cross-cultural, cross-disciplinary conversations and be able to hear other voices. But just
actually, Ted, on that note, it's interesting. I do some teaching, just one session with our medical students on cultural and religious differences among patients that we care for, and I've had occasion to read some literature. I'm no expert in this, but I find that a very interesting example that can be learned from is the Southeast Asian context. And I'm not trying to stereotype or generalize here, but I have in mind an actual article written by someone from that cultural context. So I'm taking his word for it, okay? And he points out that in that cultural context, family sovereignty is the thing rather than individual autonomy. As such that in end-of-life care, a decision of the patient will only be followed if the family agrees with it. It's really striking how different that is. And I noticed when I was looking at information about the New Jersey law regarding MAID, I realized that they actually track whether or not the patient is going to talk about this with their family. And it's interesting how the patient doesn't have to do that. And I found that to be an interesting sociological phenomenon. Right? That the expectation is, you can do this as an isolated individual if that's your choice. Whereas in other parts of the world or other cultures within our country, that would just make no sense at all.
It's also, though, a problem, this cultural difference, because in those, and Asian cultures is not the only one, but in those situations, it isn't just, we have to talk to the family and not just let the patient decide. Sometimes the family members of a terminally ill patient will say to the medical team, don't tell her she's dying. That's for us. We're here to take care of her. She shouldn't know. Well, I'm not trying to evaluate how that works in Asian or Asian American culture, but that contradicts our understanding in the Western world that patients have a right to know that they're dying and be part of the decision-making process. So there's really a very complicated clash of cultures there.
Right, yeah, that big question of veracity. But I'm going to steer us back to medical aid in dying, and also the word that had been used is physician-assisted suicide, because one of our questioners wanted a little bit more discussion on noticing the differences in language that you two were using, and wanted to see if there's any more dialogue between you all about language.
It's very important to me not to say suicide, because it's different from what we think of as for the reasons people usually commit suicide. They want to end their lives because of mental illness or situation or whatever it is. But in this particular situation, the people who turn to medical aid in dying do not want to live. I mean, they were told some time ago that they have a disease that's now going to kill them, and that's not what they want. And it's insignificant, but what they want at the end is how they're going to die. Agree with that or not, I don't think that it's the same as suicide.
Yeah, I guess I would be more in favor of just a plain use of language, right? So literally, if right now I had some pills here on my desk, and if I decided, well, I'll take these pills, there would only be one reason. It's because I actually want my life to end right now. I can see no other reason. So yes, along with Nancy is saying, you could say, well, it's because of the context. So if I didn't have a terminal disease, no, I wouldn't take the pill. But that's that. We can say this and that, rather than to pretend that the intention, it's just the philosophy of action, right? And in purpose and intention. I intend that. So when I gave just a simple dictionary definition of the word suicide, it's actually reflected in the initial statutory language that New Jersey used. So I would say it stands to reason that that's what it is. But I know from other literature written by physicians who are supportive of medical assistance in dying is that they're very concerned about the stigmatizing effects of the word suicide. And I understand that, but I guess to say the solution to that is not to deny what's happening and deny the plain use of language. It's to stop stigmatizing. It's to have mercy on people who attempt suicide or who have committed suicide, and to not mistreat them or misspeak about them, et cetera. So I think that we need to be straightforward about what the intentions are and not to deny them.
I think I laughed because in my world, there's something called the plain sense of scripture, so that we should just be able to read the Bible, just look at what it says, that's what it is, and know it. Plain sense of language to me is sort of parallel. No language is unbiased. I agree with you that we should try to be as clear as possible. But I think there is a key difference in perspective if you call it suicide or if you call it aid in dying, so that one is not clearer than the other. Each represents the position that you hold.
What we're talking about here reminds me of conversations I've had both with my palliative care colleagues and then also colleagues who work in the field of suicide prevention, suicidology. And even the word committing suicide is loaded because it talks about there being an illegal act that someone has committed versus either attempting or completing a suicide. Yeah. And I'm also pulling back thinking of even language around hospice and palliative care and how that gets confused and what people think of when they hear these words. How do we change people's understanding of words? Is that easier than just changing sometimes the words? And I'm just noticing that.
If I can also add, it's too bad that Dr. Israel's not here so that she can join the conversation. But I did pay particular attention to the way she said that this is not suicide or assisted suicide, and she was saying it's because the doctor's not assisting the patient. And I thought, well, that's curious because I think, and then the way, if I heard her correctly, correct me if I'm wrong in recollecting this, is that she was saying that assistance would be, I as the doctor have the actual medicine in my hand, I hand it to the patient, or I put it on their tongue and then they ingest it. Something like that. Whereas from my vantage point, then it raises the question of what's the definition of assistance? Mm-hmm. Okay. And so the question would be is a person who evaluates a patient, makes a diagnosis, determines their decision-making capacity, and then engages in shared decision-making, and then prescribes a medication. If that's not assistance in the plain use of the word, I don't know what is, quite frankly. So I think that once again, I think it's always going to come back to a fundamental disagreement about a controversial ethical question. Yeah. And I think that to just somehow just say that language can be shifted and used in different ways, I think we would all do better if we just have an honest disagreement and agree to disagree at a certain level.
We're talking about language. There was a question that came up, maybe for definition's sake, for people who might not have a lot of experience in that. I wanted to clarify a difference between empathy. I think, Dr. Kaldjian, you were talking about empathy and countertransference. And so the question is, can you maybe explain a little bit about those differences? And can you be empathetic and not have a countertransference experience? And really, I guess the question here is, should physicians be empathetic, which is an interesting question. So see what you think about that, and maybe Nancy, you can respond.
Yeah, Nancy, you want to go first on that?
Well, I think that's a more technical question, the difference between those two. And I have heard of counter transference in the ward on eating disorders, where that disorder is highly secretive. The staff can become highly secretive themselves. So I understand that. I would just go back to how many of us actually have this relation with physicians where they are empathizing with us. So before you even get to counter transference, that too often it doesn't happen. And we're back to this question of trust. So that if you want a physician to be in relationship with me and even challenge me maybe to change my perspective, I have no objection to that. If you're talking about my primary care physician who knows my children's names, who's known me for 25 years, I would have huge objections that now you are giving the doctor the authority to try to manipulate. It's no longer just help see another perspective, because that doctor, more often than not, isn't going to know me.
Mm-hmm.
I think it really, it's a great question. And I haven't actually had that question posed to me that way before. And I'm not a psychiatrist. I have a passing sort of grasp of transference and countertransference. And so I enjoy reading psychiatrists, and I'd be happy to send people articles about that who write about this. And one definition of empathy, and I'm drawing from some notes I have here, would be the ability to understand the perspective of the object or person of our compassion, right? And that's somebody named Gilbert used that definition. There are a lot of, I find empathy challenging to talk about because people have quite differing definitions of it. And even the idea of empathetic resonance, feeling something that my patient is feeling, I find that to be quite mysterious actually in terms of how that works and the difference between compassion and sympathy, et cetera. But if it's about understanding the perspective of the patient and feeling something in relation to that, I guess in my mind, there's a real sense in which it's about the patient. It's about my patient. It's about the therapeutic relationship oriented to them and their good. Whereas countertransference has to do with something that's going on inside of me. For instance, the fear of death. So that example that I all too quickly went through was the sense that, if a physician is experiencing their own frustrations with not being able to solve the patient's problem and to address the patient's deep affliction and complaint, and then the patient says, well, maybe I should avail myself of MAID or assisted suicide, the temptation, if I can use that loaded word, for the physician might be, oh, this will also be a relief for me rather than a relief for my patient. So who is this about? And I think that's why physicians, if they're really good physicians, they have, if I could use the word mindful, they're mindful enough to think, well, maybe I'm actually tilting in this direction for some other reasons. Maybe I should check in with a colleague or a trusted other to tell the story and have some dialogue and see maybe I'm not thinking and feeling this the right way. So that'd be my first approach to an answer to that.
Yeah, I'm just hearing this, and from my own perspective here as a chaplain, thinking that that's kind of ground for us in our practice is understanding transference and countertransference, things that are happening in a relationship, and really trusting that empathetic response, knowing that we feel what others feel if we're in true empathy with them. It's so interesting to start having this dialogue around what happens in that patient-physician or patient-practitioner relationship, what's going on both with the patient, the sufferer, and then also with the one who's trying to provide care for them. The complexity of those interactions isn't something I think either of them are usually aware of. You were saying, Lauris, it's not something that goes into medical school training necessarily. And it doesn't necessarily go into seminary training either, Nancy. Not all of our clergy understand those dynamics. There was, speaking of chaplains, there were some questions that came through the chat feature as well, and I'm trying to go back. So I'm flipping between two different dialogues going on. So if I look a little schizophrenic, I apologize. But it talks about benefit or burden of care when nothing further could be done in the end of life. This person has worked with physicians who were consulted chaplains in end-of-life care, keeping someone on, for example, on life support when nothing else can be done. So chaplains called to be working with physicians. And so I guess the question here is more of how do you see chaplains being part of some of this, potentially part of this dialogue as we're discussing options around end-of-life with people?
The hospital where I'm on the ethics team, I consider they have an excellent chaplain, and his predecessor was equally good. And I think it's a wonderful example of where people respect the chaplain. They also have a psychologist who often goes around. They were on the floor during the pandemic trying to make sure that people weren't overwhelmed by the horrible things that they were experiencing. So in that way, the chaplain really is, maybe not in every case, depending on who the attending is, but the chaplain really is considered part of the team. But I know that there are other hospitals where that wouldn't be the case, and maybe they wouldn't have as gifted a chaplain. So it's an institutional question where I hope that chaplains would be respected, but also then that it's a relational thing that needs to be fostered and worked on.
Yeah, I think this is an extremely important issue, and I unfortunately have too many experiences of being involved in ethics consultations where it's clearly the case in my mind that there are spiritual needs going on. In one sense, there are those needs all the time, but sometimes quite explicitly so. And then you find out that there's been no pastor, chaplain, rabbi, anybody else involved. And so that's one of the simple things that one can then suggest in terms of then having the ability to have a goals of care discussion that's framed by, situated in, contextualized by the actual deeper, broader, what I call foundational beliefs and values of the patient and family. And then that remarkable work of integration. I guess it's a bit like some people would like to use the rubric of motivational interviewing, right? Where you find out what's of greatest value to the person with whom you're speaking and possibly having a disagreement with, and then anchoring the facts, the stories, the movement of the patient's illness in that framework so that it can actually make sense at a deepest level. And then sometimes, I mean, even to ask a patient or family, is there someone outside of the hospital who you trust as a spiritual advisor in some way, who we could call upon? Would you allow them to participate in this conversation? And just that act, it's a wonderfully dignifying and honoring act to say, we want, in a sense, put you in your own living and spiritual space so that this can actually be a meaningful conversation for you.
The flip side, I agree with all of that. The flip side of no chaplain, no rabbi, no one was there for this patient when it was needed. The chaplain's office at our local hospital is trying to encourage physicians, if you're about to go into the room and tell a patient something awful, really bad news, let us know so that we may have a relationship with that patient. And when you leave, we can be there. Now, you even mentioned maybe something, more people present to present. But I think there's a real need for physicians and chaplains of a variety of religious perspectives to be involved in patient care.
Yeah. It's interesting, another question that came up as we're talking about who's involved in all of this was pointed out, this is a conference was invited a lot of different disciplines to be part of this time together. And one person is just noticing that nurse practitioners at this point really haven't been connected into how this might be working as well. Can either of you speak to that aspect of who is the practitioner, who is the person who's caring for it? And again, here we're tripping over language. Is what do we call the people who are carrying out this law?
My sister is a nurse practitioner, though she worked with people who were dying at home, people with AIDS decades ago. I'm not exactly sure the structure of a hospital, how it includes nurse practitioners, but I do know that at most hospitals, the bedside nurse, there's a huge need to have her usually, but sometimes him, to be integrated more into the team. There can be a meeting about this patient that decisions are made, and the bedside nurse isn't always there. And the bedside nurse is the one who tends to know the patient best day to day. So that however nurse practitioners work in, I'm not sure, but I think there needs to be respect for all of the members of the medical team being included in decision making.
I would add, it's interesting, you all know your POLST form and what's on it. And I noticed that like Iowa's as well, I like New Jersey's better than the one we have in Iowa because your first section on that POLST form is goals of care. That's so important to have the big picture up front. But for signatures, it says a physician or an APN. I assume that's for an advanced practice nurse. like a nurse practitioner. So it's a very interesting question these days, who is authorizing or who's prescribing what. But I'm assuming it's the case, right, that in New Jersey, legally speaking, this is a physician prescription, right? There's no one else is allowed to do this, no other licensed independent practitioner. But at the same time, any good physician, if I can use that wonderfully loaded adjective, knows that we need to make sure all members of the team are having a voice to especially advocate on the part of the patient and to participate in and contribute to a best and wisest understanding of the way forward.
There's a question here, and I think it's also interesting talking about prescribing and the care of people at end of life. It talks about administering opioids, particularly morphine, at the end of life. And I think, if I'm recalling, Nancy, you were talking about palliative or terminal sedation as an option that's out there. So I guess the question here was talking about, and maybe explain a little bit more, isn't that just an option, just to push a large dose of an opioid and then make things happen quicker? Isn't this, basically they're saying, is this the same thing as what we're talking about?
Well, having access to administer more morphine for yourself is different, I think, than what I will say terminal sedation, where someone else is giving you medication to make sure that you don't ever wake up, that you're unconscious, because the pain would be unbearable otherwise. Some people would agree with that, and so I wouldn't want to talk them out of it. But in situations like that, the human person who is just reduced to a body that breathes in and out, and for me to say that, to me, is not that's not a life worthwhile. Then I want access to physician aid in dying before I'm just reduced to an unconscious body.
This is a really important area, because I think that there's a fair amount of misunderstanding, and it's very useful to go to websites of the major palliative and hospice and supportive care organizations in this country. And again, I'd be happy to send resources to anybody who doesn't have immediate access to that, because there are statements that make it very clear that there's a very well-established place for, some have called it terminal sedation or intensive sedation or intensive palliation. It's got different words, because sometimes that phrase terminal sedation can suggest to some people the purpose is to terminate the patient. That's not the kind that many of us are wanting to say by this. It's actually to treat symptoms. And so you literally use the medical nursing idea of titrating a medication to the symptoms. And it's not just pain. It could be nausea and vomiting. It could be seizures. It could be, all the things, restlessness, et cetera, or agitation. And the good news here is that palliative care providers are really good at this. And when I talk to palliative care providers at our hospital, they will tell me how this goes in actual real cases, and they can do it. I personally have never heard of an instance where someone had symptoms that could not be controlled. But Nancy's point is well taken, that if by the point you've controlled the symptoms, a patient is no longer conscious, that's a reality we all have to face squarely. And if that is seen by some people as dehumanizing, well, that's the position they take. For others of us, it would be, take this for what it's worth. It's not a great analogy, but do we think that when someone's under general anesthesia, they're less than human? No, they're not. It's a temporary state. So we're not wishing this. Consciousness is such a beautiful gift. It's so deep to our existence as human beings. But when contrasted or when situated in the actual circumstance, it might actually be justified. And the last thing I'll say here is that really good palliative care docs and nurses, what they can do is they go through a beautiful process of shared decision-making and informed consent, and they ask a patient and say, what's most important to you? What are your most important goals of care? Is it pain relief and symptom relief now versus do you want to be alert and awake to interact with family members, to pray, to whatever it might be? And then what's really neat is you can actually regulate this so that you give the patient time of rest, and then you lessen that sedation appropriately, give them time with their loved ones, and then, in a sense, put them back to that gentle, more restful state. So it can really be titrated. But the point is, the person who asked about, well, couldn't you just give more morphine? No, the intention then is you want to hasten or end the patient's life, right? That's not the purpose of palliative sedation.
But that back and forth is great if that works. But once you give less of that, then you're back to acute pain or nausea or all those things that would not make it possible for me or others to relate to my family in the way that I want to. And I'm not saying that it's not a human person. I'm just saying the human person, we're whole. We have bodies and minds and emotions and spirits. And once you're reduced to an unconscious body, then you're pretty much treating somebody like a body. Again, I have nothing against people who want to choose that, but I do think that when someone says, I don't want that. So Brittany Maynard, she had brain cancer. She knew the kind of death that she was going to experience, and she didn't like the alternative of terminal sedation. To me, just means you're sedated until you die, though you're saying that's not always the case. But I think that someone should be able to say, no, that I don't want to spend my last days and all that money and time not being able to communicate with my family and just being unconscious. I am not just a body. I'm not just consciousness either, but I am a whole human being, and I don't want to be an unconscious body.
Just to speak of this, interesting that we're having this part of the conversation. Early in my career as a chaplain working in hospice, did have an opportunity to work with a family and a patient who decided on palliative sedation, terminal sedation, however the name was used even then. It hits to your point, Lauris, that it's the moral weight for all of us who are a part of that team of being part of that experience for this youngish man with teenage kids and a wife, but knowing that for him and his family, they'd come to this decision, still weighted on all of us as we gave him medicine to make him sleep for the rest of his life, how short that would be. So it's all loaded. It's really loaded. I think what I'm gonna do is I'm gonna hit one more theme of questions that came back, and then maybe give the last 15 minutes to let participants raise their hand and then speak to you all, because I know some of these questions are more nuanced that I'm trying to quickly summarize them. And I think that might be nice to hear from some of our participants. So let me just kind of roll back to one series of questions and kind of connect them, which is, again, back to economics. One side of it, a questioner was looking at how does the insurance industry and our insurance and payment system in our healthcare system influence this discussion, and also just the broader, what are the economic issues that are really pushing people to make decisions around this end-of-life care?
I can only address the latter. I don't know about insurance, but it is a real fear that this shouldn't be used as a cost cutting. Lauris raised that someone is choosing this or being encouraged to choose assistance in dying because it's going to be less expensive that way. So I think that's a huge issue we need to be aware of. On the other hand, the biggest medical cost we have in this country is spent in the last few months and weeks of somebody's life, and I think that's problematic.
It's interesting. I don't know, the data. My general sense as a physician and ethicist who tries to pay attention to things and looks at the headlines of major journals and whatnot, my understanding is that palliative care is available for people who need it in this country. And if somebody can point out to me where that's false, I would very much, I have a moral responsibility to know that. So I'd like to know that. And I'm not saying that access is always straightforward, but the point is that there are funding mechanisms for this. I think our society is of one mind that this is a vitally important thing, okay? What's interesting, the slide that I showed about from Oregon that actually shows the data, the bottom line that I didn't have an arrow beside was financial implications of treatment. That's not the assisted suicide treatment, that's just the ongoing treatment. And over the last 20 plus years, that was only affirmed by 4.5%. So anything above zero is of concern, right? So I take that really seriously. I guess the good news is that it's in more than 95% of cases, it's not a concern. Mm-hmm. So that tells us then similar to what Nancy was saying about how we need to all be committed to doing what we can to the utmost to care for people who are in this profound state of need. And that includes financial care, right? So how often do we inquire with our patients about, do you have financial concerns? You know, it's interesting. I talked to some students about this question of, should we discuss costs of care with our patients? And I say, that's a dangerous sort of piece of ice to stand on, because if you do it the wrong way, a patient might look at you like, well, doctor, are you not wanting to spend as much money on me? Is that why you're raising costs? Or are you doing it because you're concerned about my concerns about costs? So there is a respectful way. And sometimes this is where we can rely upon other team members. If the social worker on the team is more accustomed to that kind of conversation, that's really important as well. And then hopefully we can find ways to be creative, to find resources that people might be lacking.
I like that idea a lot, that the social worker could ask that question and talk to someone. I think Lauris is more optimistic than I am, that everybody is in our society is concerned that people have good care at this time of life. I just think across the board, that's not true. Try to find good care for someone who has Alzheimer's, and you're just in a world of really bad care for incredible price, because our society doesn't want to make good care affordable. And I don't have any reason to think that end of life care is, as a society, we want to put lots of money into making medical care better at that point. I just think we have a problem with our medical system, and people saying they don't want to pay for somebody else to have access. They earn their money and they just want what they deserve.
I'm reminded of the Dartmouth Atlas study, probably about as almost a decade ago now, that showed how bad New Jersey is about that. The highest cost of end-of-life care and worst outcomes. So, whereas
Utah has the lowest cost per person and one of the highest rates of good success in treating people.
Yeah. So it's interesting how this might be influencing the discussion we're having too around this particular type of end-of-life decision. So what I thought I'd do is, like I said, take the next 10 to 15 minutes that we have left and invite people to speak themselves. And if you want to ask a question, just use the raise hand button at the bottom of your screen, and it should pop up on my participants list. There's 140 some of us at this point, but I will do my best to call on you, and then you should be able to unmute yourself. Our host will help us with that, and ask your question so that I'm not filtering it, but you can go ahead and ask directly. So if anyone has those. I have a few other Q&A that are on the list, but I thought it might be nice to hear other voices besides mine. So Marie has her hand up. So if you want to mute yourself, Marie, you can go ahead and ask your question.
Hi, good morning, everyone. I was just thinking about the impact that this would have on life insurance policies, and if we know how that will play out for family members, because suicide is something that is that has a negative impact.
Right.
And is this considered in that category?
This is so interesting. I need to look up the answer to that question. Almost every time I've given a presentation on medical aid in dying, including in South Africa, someone has asked that question. Well, if you have assisted death, will your family not get life insurance? I think the answer is no, but it's really not my field. But now that this question has come up yet again, before I enter into this conversation, I'm going to look that up.
Yeah.
Can I just say, I'm looking at the copy of the statute on my other screen here, and it's C.26:16 to 14, and its provisions in certain documents would not restrict requests for medication. I'm not a lawyer, but a quick glance at those paragraphs tell me that that's all covered.
I think
so. If there are any lawyers who know this, or anybody else who knows the statutory law who want to correct me, please jump in right now. But I think that's such a common concern that that legislatures deal with that right up front.
I think that's true.
Which may be one of the reasons, and again, it's been years since I read the law, but I think some of the thought about obfuscating the reason at the top of the medical examiner and death certificate report would maybe be an insurance issue and life insurance issue. Chani, you had a question. Should be able to unmute yourself.
Thank you. Thank you. I've been social worker.
I think we just lost your audio, Chani. You want to try again?
Keeps getting muted again and again.
Okay, keep on going. We'll push through.
Okay. I've been social worker at Muhlenberg at Robert Wood Johnson and worked with kidney dialysis patients and a lot of other things. My sister died of ovarian cancer, suffering. I also come from South Asian family, and it was interesting to hear that my sister's family wanted treatment to go on, but we had really difficult time seeing her suffer. I am so glad that now there's a law. I wish people knew about it. I didn't know about it till today or till I signed up for this. In fact, I learned from people suffering that I would like the choice myself. I'm so glad that it is there. Coming from also South Asian family, they are also families say, stay with the abusive husband. Stay, don't tell anybody. Don't tell the patient who's dying or a person will get depressed and die. So, it has raised all kind of emotions in me. And as a social worker, we made sure again and again that person knew what they were doing. And this option was not available. Only person I knew is that the person's son was a doctor and still psychiatrist, social worker, theologian people got involved before she terminated her dialysis. I think I would like to see more options for ALS, kidney failure, that people be allowed to go on their terms rather than keep suffering, rather than be dictated by the doctors or people who feel righteous that we should suffer.
So, Chani, I appreciate your story, and it's really touching me. Maybe I'll let Nancy and Lauris respond.
A couple of things. I do think this law was better known when it was being debated than once it was accepted. So there is a need for people to know whether they agree with it or not, that it's there, so we know more about it. I also, in that line and with the last comment about ALS, people need to know what VSED is, voluntary stopping eating and drinking. It's legal in every state. It's complicated, but it is. Lots of people in ALS choose to do that at the end of their lives. It's just something we should be aware of. But also just that the Asian culture's tendency to emphasize family instead of individual. In this country, we emphasize individual, not just instead of family, but that's not the emphasis. There are pluses and minuses to both of those. So I greatly appreciate that we need to be more family oriented and not just emphasize autonomy. But as has just been pointed out, it can come with problems, that it can turn into one member of the family being tyrannized by another, being told what you have to do. And so it's, we can't evaluate cultures except by saying this is what we really appreciate about it. But we also have to be aware of potential problems that sometimes are culturally in place.
Lauris.
Many issues are brought up by the narrative we just listened to. And it's interesting on this cultural question, I don't know if you have in your hospital systems, people who are listening, what we have in our system, we have a subscription to this product called Culture Vision. And so you can go online and find out based on where your patient is from or what cultural background, you can learn about that culture. There's, of course, the paradox that you run the risk of stereotyping by actually wanting to be culturally sensitive. I think this is a profoundly important question because we are in a time and place historically where we do care about other cultures. And yet when we disagree with that culture in some way, now we start to have this sort of almost a cognitive dissonance or a friction. And so that also raises the question of physician or nurse or social work integrity or conscience, because we want to accommodate our patients and their families as much as we can, but we can also reach a limit. So if a family's saying, we basically want you to deceive the patient, some of us would say, I can't do that. I can try to navigate and negotiate some kind of a compromise, but now you're asking me to go against my core beliefs in that sense. So the cultural question is always going to be a challenge in some cases. I think probably the good news is that if we're patient, respectful, compassionate, we can usually find a creative way that is satisfactory to all parties concerned. The question of the last comment that the speaker just made about righteous and asking or expecting people to suffer, that is not what I'm trying to say, right? I'm saying on the one hand, if the goal of life is to eliminate all suffering, that's a project that has devastating implications for human society. And that's not the point. I think then, as Nancy even said, that when suffering doesn't have a purpose, okay, so that just shows us how loaded this is. All I'm saying is that when the other, in addition to concerns about alleviating suffering, you have the question of what is the physician's role in society? Is the physician a healer who will not hasten or cause death? Or can that be incorporated? Historically, and in the current time, there are deep disagreements about that. So we have to be honest about the implications of that stance. And I quite frankly think that many people, certainly outside of medicine, possibly inside of medicine, are too optimistic about physicians. They give physicians too much credit to think that somehow you can start to do certain things and that doing will not affect your thinking and your feeling. Right? We actually, if anybody who knows anything about virtue ethics knows that the more you do something or don't do something, it actually is part of your own character development. And so what some people call an attitudinal shift can occur, right? In terms of now thinking, well, it would be good for the patient if they chose this sooner rather than later, and for all sorts of reasons.
So it is interesting there is a tension between what an individual in the context of their culture might be deciding and what influences the decisions they want to make, and then the nexus with the providers and the team, the clinical team, and their own cultural and moral and value-based ways of entering into that decision.
So it becomes a moral question, how far does the medical team go to be respectful of another culture? And it can't even be subcultures. There's a often repeated case from years ago at our local hospital where very conservative Christian family, a young man was dying, their family member, and they went to the medical team and they said, we don't want you to give him pain management. He deserves to suffer. And they were hoping that would change him. Well, see, that's a clear one. They were like, we don't do that. So you can say no to that. But when you get into really, truly wanting to be respectful of different cultural understandings of family and decision making, there still is a line where, Lauris, you even said it, a doctor may have to say, I can't not tell the patient. That is my responsibility. Nurses might be the same, but it is incredibly complicated. I want to look into what that is about cultural vision. It's one of the biggest questions in the hospital is people saying, help us understand other religions other than mine, other cultures, and how do we negotiate this? It's great that we're now trying to deal with that, but it is really complicated.
And in the context of New Jersey, with so many different cultures in the mix here, really is fascinating and frustrating. And we won't have time to maybe dive even deeper into ideas between, as I see it, cultural competencies and cultural awareness and cultural humility, which I think is another guidestone or guideline. We're almost
can I just say, Nancy, I just sent in the chat box the link to this product called Culture Vision. If anybody wants to learn about that.
We are going to need to stop here. I want to thank Lauris and Nancy for this really rich conversation. And there were tons of other questions we didn't get to, and several hands that just never I got to be able to acknowledge. I'm going to turn it over for the last couple minutes to my colleague and friend, Dr. Raynard Smith. And Raynard, you're going to tell us what we need to do to get our CEUs. And thank you guys so much. Really rich morning together.
We've come to the end of our conference, but the conversation does not have to end. You have access to our speakers. We'd like to thank our three invited guests, Dr. Jessica Israel, Dr. Nancy Duff, and Dr. Lauris Kaldjian, for bringing their expertise to help us begin this conversation on this very, very important issue, medical aid in dying. So I want to thank them again. I also want to pay tribute to the John Suydam Kuhlthau Bioethics Steering Committee. We have worked close to 2 years in producing this today. And I want to say to the team, it has been worth it. It has been worth it. And so I want to thank Olivia Rivera Mamara, Reverend Ted Taylor, Dr. Amar Bukhari, Dr. David Cohen, Reverend Christine Davies, Reverend George Akins Jr., Peggy Morgan, Claudia Pagani, and Reverend Marticia Kennard Dwyer. Also, kudos to Reverend Steve Mann and Amanda Brule, who have helped us navigate this virtual space. They've done a wonderful job. And also Alfredo LaCroix for being the one to help us get the material out to you all. I hope that you found this coming together today beneficial, and that you will that you won't let the conversation drop, but that you will take it back to your respective places of institutions of employment and have further conversation that will help us as we, especially here in the state of New Jersey, and I think there's 8 other jurisdictions that have enacted this law. We need to have this conversation. We all know that we want to engage families and patients and families with compassionate care. We all talk about that. And so having this conversation can help us to do just that and accomplish it in a great manner. Again, I want to say thank you to all who have come, all the attendees. You have made it really worth our time. That is mine and the steering committee's time of sitting together and really teasing out this issue. We again thank Dr. Lauris Kaldjian, Dr. Nancy Duff, and also Dr. Jessica Israel for their expertise and for their way that they modeled the conversation. That one can have opposing views, but yet can have a civil conversation on the issue. They modeled that quite well today. I want to thank you all for coming, and please, you can look forward to receiving your certificate, which will probably come out in December once we tally everything and we have our post-conference meeting. All right, want to wish you well and have a great day.